everyone, this is Caitlin back with another literature review. Today we are looking at the TRACE-2 study, which is Tenecteplase versus alteplase in acute ischemic cerebrovascular events, a phase 3 multicenter open-label randomized controlled non-inferiority trial out of Lancet. A little bit of background, IV alteplase has been recommended as a standard therapy for eligible patients who have had acute ischemic stroke. Tenecteplase is another thrombolytic that's been gaining more attention as a possible alternative to alteplase, as its dosing and administration are more straightforward. Tenecteplase is given as a single bolus over 5 seconds, as opposed to alteplase, which needs the first 10% given as a bolus over 60 seconds, and the remaining 90% as an infusion over 60 minutes. There is some other discussion about whether or not we should be using thrombolytics for stroke at all, but that's way beyond the scope of today's discussion. As of right now, the AHA guidelines give a 2B recommendation for Tenecteplase being reasonable to consider over alteplase for patients undergoing thrombectomy based on the results of the Extend IA TNK trial. So TRACE-2, the study we're looking at today, as mentioned in the title, is a phase 3 multicenter prospective open-label blinded endpoint randomized controlled non-inferiority trial across 53 centers in China comparing 0.25 mg per kilo Tenecteplase versus 0.9 mg per kilo of alteplase. What I found interesting about this study is they looked specifically at patients who were either not eligible for mechanical thrombectomy or who refused thrombectomy. So it's a different population than where most of the Tenecteplase literature is currently. They included adult patients within 4.5 hours of onset with a baseline MRS score of 1 and a disabling ischemic stroke with an NIHSS score of 5 to 25. In addition to the exclusion of patients who are going for mechanical thrombectomy, they used the standard thrombolytic exclusions in the guidelines, and they note that the Chinese guidelines are similar to the US and European guidelines. This study was sponsored by the drug company who donated both agents, but otherwise didn't play a role in the study design or analysis. So the results. They did enroll around 1,400 patients with approximately 700 patients in each group. All included patients were Chinese, and the baseline characteristics were really well balanced between the two groups. Their primary efficacy outcome was the proportion of patients with a modified Rankin Scale score of 0 to 1 at 90 days, which occurred in 62% of the Tenecteplase group and 58% of the alteplase group for a risk ratio of 1.07. This showed that Tenecteplase was non-inferior but not superior to alteplase in this patient population. Secondary efficacy outcomes included functional neurologic outcome, which was a MRS score of 0 to 2 at 90 days, MRS at 90 days, improvement in NIHSS at 24 hours and at 7 days, or at the time of hospital discharge if it was before 7 days, and quality of life at 90 days, all of which showed no significant differences between Tenecteplase and alteplase. For their safety outcomes, the primary safety outcome was symptomatic intracranial hemorrhage within 36 hours, which occurred in 2% of patients in each group. Their secondary safety outcomes included symptomatic intracranial hemorrhage within 90 days, parenchymal hematoma 2 within 36 hours, any intracranial hemorrhage within 90 days, other significant hemorrhagic events in 90 days, deaths, adverse events, and serious events, adverse events, again, none of which showed significant differences. One secondary safety outcome that did initially stand out to me was the rate of parenchymal hematoma 2, which is defined as hematoma of greater than 30% of the infarcted tissue, but also extending beyond the initial area of infarct. While this type of hemorrhage isn't technically by definition hemorrhagic transformation according to AHA, it can be suggestive of it. This occurred in 10 patients in the Tenecteplase group and 3 patients in the alteplase group. This wasn't significant with a p-value of 0.053, but I did think it was worth mentioning. However, I don't necessarily think this is something to be concerned about just yet, however, especially since other Tenecteplase versus alteplase studies also found an insignificant swing, but they found it the other way, with alteplase potentially having more patients with these types of hemorrhages. So I do think that we can trust the statistics on this one right now and chalk it up to chance in this instant, but definitely something to keep an eye on as more data comes out if this is a signal or if it is just some background statistical noise. So in conclusion, the authors found that Tenecteplase was non-inferior but not superior to alteplase for acute ischemic stroke within 4.5 hours of symptom onset in patients who are not eligible for mechanical thrombectomy. Their results support the implementation of IV Tenecteplase 0.25 mg per kilo as an alternate thrombolytic therapy to standard of care alteplase. So, what are my thoughts on this study? Overall, I do think this is a good trial. I think the design was appropriate. I'm not concerned with the manufacturer sponsorship since both agents do come from the same company. At first, I admit I was a little unsure about them targeting a specifically a non-thrombectomy population, as most of the literature supporting Tenecteplase is in a thrombectomy population. But then I realized I actually do really like that because that's where we need more literature. They're not doing another thrombectomy study where we kind of already have that signal. They're going and digging into that area where we don't have a ton of information. So while the AHA guidelines right now do only have that recommendation for Tenecteplase in thrombectomy population, most centers that I'm aware of that have transitioned to Tenecteplase, my own included, transitioned for all strokes in order to have one cohesive process and reduce the risk of error or using the wrong thrombolytic or mixing up the dosing schemes. So I do think that this trial provides more support to centers that want to make that all-in switch to Tenecteplase as their workhorse thrombolytic for stroke, rather than keeping alteplase and Tenecteplase on formulary depending on thrombectomy status. I personally support the transition from alteplase to Tenecteplase as the primary thrombolytic for acute ischemic stroke. If we're going to use the thrombolytic, I think Tenecteplase is the better option overall. From all of the data that I've seen, the safety and efficacy are pretty much equivalent, but the ease of administration is huge to me. It's been so nice having the simple diluent in, straight draw, 5-second push administration process versus the transfer spike, draw the bolus, draw the waist, don't mix up the bolus and the waist, give the bolus over 60 seconds, don't push it too fast, prime the line, start the drip process that alteplase entails. I personally haven't seen the data yet, if it's out there, because I do work in a comprehensive center, but I do also think that Tenecteplase may speed up the transfer process from your primary stroke centers to your comprehensive stroke centers if indicated. At least, again, in my county, we only have 2 critical care ambulances that can actually run drips. So if you have patients who are on IV infusions, you have to wait for one of those 2 critical care ambulances. So avoiding that by giving the Tenecteplase push and letting the medication be finished will allow for potential faster transfer times, since at least where I'm at, the standard EMS crew can transport immediately post-Tenecteplase. So all things considered, if I have 2 drugs that show equal efficacy and equal safety, one is easier on the nurses I work with, I'm picking the easier agent every time. It also helps the argument as a last side note that at least where I am, Tenecteplase costs half of what alteplase does. So while I'm not out here picking a therapy solely based on cost, again, all things considered, if it's easier, if it's cheaper, and just as safe and just as efficacious, I think that's an easy decision to make, but I know not everyone has obviously that same thought. I personally support the use, again, of Tenecteplase over alteplase, and I do appreciate this study shining more light on the non-thrombectomy population, because I do know that was a sticking point for a lot of people and a lot of centers in making the full transition to Tenecteplase. So I'm not sure where the future of thrombolytic therapy in acute ischemic stroke is going overall, whether that's continuing with thrombolytics or moving into a more intervention-based approach. But I think if we're going to stick with thrombolytics, I'm all in for Tenecteplase.